In this video, I'll be responding to comments from our last video last week, benefits of testosterone replacement for men. I'd like to use this type of medium more often as I'm seeing some great questions on my channel, and I want to encourage that. I want to get more interactive, obviously. So please, if you like the videos, please subscribe, and please like, and please leave a comment, because I'll do my best to get to them. In the future, I'm adding webinars around the world. It will be called Strong and Healthy webinars with Dr. Thomas O'Connor, the Anabolic Doc. With no further ado, let's get right into some of these great questions. I've highlighted these. The difference between topical versus intramuscular testosterone. Great question. Ross Walker versus Lex Skywalker had a great dialogue right here. Essentially, what are the differences and are they evidence-based? So, great question, gentlemen, and you had a nice dialogue. Let me pick up and see if I could add to this from my expertise clinically over almost 20 years now of being involved with this. So, intramuscular testosterone versus topical. That's the topic, because that's what we really have. We have a Testopical we can place in the subcutaneous. We have buccal, and we have in Europe they have a testosterone undecanoate pill that dissolves and transmits through lymphatics, avoiding the first pass effect. Beyond the scope of today. Topical is easy. Topical is not injections. Men who are terrified of injections, they obviously have to go topical. Topical can be good in that respect. Otherwise, topical spreads to partners. Big question these guys brought up. Good job. Topical has there's a variability in its delivery. And the effects, the cognitive effects and the positive beneficial effects, I really see to be less versus small intramuscular doses of esters. This is the truth. But the reason is because with the intramuscular injected esters, you're getting a disparity between the total and the free. You're getting more free, higher free, that can saturate and stimulate those receptors in the central nervous system. I've discovered this, and some other experts have too. And it's incredible. So, but what comes with that disparity of the total versus the free with the intramuscular esters? You can have side effects. And the obvious side effect of the injection is infection. It's a cellulitis. You can get pain and swelling at the injection site. You can get sterile and unsterile abscesses. As far as and everyone knows this. So as far as what I've discovered, I've also seen very interesting relationships to polycythemia, edema, hypertension, lipid changes, HDL, LDL changes, and other endothelial aspects. As a biologist and an expert who I consider myself an endotheliist, which is an expert in that inner wrapping of the artery that can cause heart disease, and that's where it starts, and how testosterone and steroids relates to that. Everyone knows that that's my love as a physician. So yeah, you can definitely get aspects that are going to be very bad with intramuscular. So what do you do with that? You take the dose down. Don't do those big doses, doctors and people. Don't do that big hit every 2 weeks to a month. You know, that bolus, that huge bolus. That's going to be, you want to do smaller, more frequent injections of enanthate or cypionate. Again, this is not medical advice, this is educational. Please see a physician. When you get the balance right, it can be wonderful. It can be wonderful. But the side effect of these frequent injections is I don't want my patients being a pincushion. And again, then you're increased mathematical risk of having a cellulitis. So to move forward, those are really the pluses and minuses. And there's no evidence-based, gentlemen, there's no evidence-based guidelines on this. So there's anecdotal, and there's some small studies, and there's some effects and discussion editorials of studies that have brought this up with physicians. Really, the polycythemia and the edema is really the piece that we see more with the intramuscular. But again, you can avoid that if you do it man to man, and you watch blood pressure, cholesterol, sugar levels, endothelial issues. If you watch that, that's how I do it. and you tailor it just man per man. That's what I do. That's the medical side when people come to see me. Interesting piece I have to add is the carriers, the solvents, if you will. The grapeseed, cottonseed, ethyl olate solvent, which is not really an oil, it's a solvent. And steroid manufacturers use that, and sesame seed oil. It's interesting in delivery, in thickness, how much you can get into the barrel of the tiny needle for the frequent injections. Cottonseed versus sesame seed versus grapeseed, reactions, how do men feel, how it converts to estrogen. Amazing. This is amazing. I fine tune and I select these with my men, man per man. That's what guys pay for with me. It's man to man. So you can't, most manufacturers, I believe, just use cottonseed oil. And I don't think there's anything wrong with that. But if you really want to go man to man and watch them, it's incredible. And that's what I do. Next questions. Let's keep moving. Alien on a bike. He's talking about that he went to a doctor and he took testo gel, which is a gel, and nothing happened. Nothing positive. He was angry and irritated and his heart rate went up. Well, did he need testosterone? Is there any other medical issues going on? What a great point here. But it's just open-ended and his libido didn't change. Well, does he need testosterone? Question mark. I don't know. This man needs a proper evaluation. Maybe he didn't need testosterone. And then is the gel going to be worse than the intermuscular? We're not even at that stage. So the next one is about levels. Razor time, Montalvo. Great question. Got my blood work done. 415 nanograms per deciliter, 28 years old. Is this considered low? Okay, no, that's obviously not low. That's obviously in the scale from about 250 to 1100. On the total, it's not low. But you have to look at the free. You have to do a liquid chromatography mass spectroscopy dilution method. Try it. You have to understand LC-MS-MS. You have to see total in the free. Young steroid users and just young men, not to mention older men that are obese and heavy, have metabolic issues, we're going to see a disparity between the total and the free. The free is the real biologic aspect that delivers and goes through and does the work into your central nervous system and has the effects on testosterone, endogenous testosterone, natural men, why they feel so well with libido and mood. And not to mention there's so many other variables. It's so humbling to do this. But you can't just look at a total, and you have to repeat it. You have to do a history. You have to take the clinical. I take the clinical effects into consideration for each man. And the Endocrine Society supports this now. It's just not just a number on paper. Next one. In your opinion, testosterone of 49, is it low? Should I consider TRT 34 years old? Well, I just talked about that. So it's a clinical decision. Next is medical decisions. Tom Harwood, 62-year-old male, bodybuilder for 30 years, naturally. 2 stents in his LV, he means the coronary artery, not the left ventricle. And hypercholesterolemia and his TRT okay. Wow. This is all I talk about. See my videos on how steroids and testosterone affects the heart. Remember, I'm an endothelial expert, which means how testosterone and steroids affects the inner wrapping of the artery. And hypertension, diabetes, and cholesterol, vascular disease. The reason why I feel so good at 54 years old is because I micromanage that with other physicians and myself. I encourage you to do the same thing too, men. Please, on or off testosterone or steroids, you have to micromanage the inner wrapping of the artery. It's all that matters. It's all that matters. That's life. Importance of close monitoring. Hatfield, 4805. Doc, I agree with you about the mental aspects of TRT. He started seeing a doctor, and essentially this goes on saying that he was on 100 milligrams, that's a half a mil of cypionate, 200 milligrams per mil concentration every 2 weeks. Typical, and I'm not putting doctors down. They see so many patients. This is all I do. They can't fine-tune this. So the levels go up and down, up and down. Not optimal. Some men, they just take it and it's okay. Most men, not. You want to do small injections more frequently, but it has to be man per man. And regarding the beginning of my discussion, there are side effects about that. Very good questions. And these men went back and forth with each other about the bi-monthly injections versus more frequent. Brilliant. Does it work? Does TRT work for older guys? I'm over 48 to 50 versus younger men. there is evidence that the studies that are mainly in older men show benefits in increasing red cells. Well, that can be a risk, actually, if it's something polycythemic and it's dangerous for you. But these are the evidence-based guidelines: an increase in bone density and musculature, obviously. And there's variability on mood and libido, but it's very quite clear that men that are stable, that have low T, if they're improved properly, their libido goes up, and there's enough data for that now. But again, this has to be, sir, done case by case, man per man. And it is younger men certainly different than older men, in the obvious fact that if you're young, you're going to be on testosterone for that many more decades. If you're 25 or 30, you're going to be on testosterone for 70-something years. I tell this to all my men. The cumulative effects, we have to think about this. Next, considering TRT versus growth hormone. Here's a man who's 42. He has low sex drive, energy, muscle loss. He's considering taking supplements, testosterone, either test supplements or HGH supplements. Please, sir, see a doctor. Consider a consultation. I'm all over the world now. My webinars are coming soon. Adding steroids to TRT because doc won't give him enough. Wow. Stephen Hill. And I'll close on that. Amazing. So if you're on testosterone from a physician, and some men do supplement, obviously, it doesn't make them criminals, but it can undermine the physician-patient relationship. So I ask my patients to be honest with me, and we always work around what they're doing. And I like to get to their goals. My goal is to have you strong and healthy and to feel your best, but to be sustainable. So if you're adding steroids, it just probably is not going to be sustainable, and obviously you can get a side effect. And those are my main videos of what can happen to your heart, to your kidney, obviously your hair loss, the gynecomastia, mood issues, sex drive up and down. But you really want to be tight with your doctor, and you want to stay in the lowest possible dose of testosterone, and you want to manage all the medical issues, mainly the cardiac, prostate, and they're complicated. I hope this helps, and I'm looking forward to more great videos and answering your comments. Thank you so much. Dr. Thomas O'Connor here. I'm glad you made it to the end of the video. If you liked it, hit the like button and please subscribe to our channel. And I look forward to bringing you more cool and interesting videos just like this in the future. Stay strong and healthy.